Hi, I'm Sharon Chinthrajah, and I'm excited to be talking to you at the virtual FAIR research retreat today on maintenance of desensitization. Current immunotherapy categories for food allergy include sublingual immunotherapy with and without follow-on oral immunotherapy, with and without adjunctive therapy, epicutaneous immunotherapy, and oral immunotherapy with and without a period of withdrawal testing, which we call sustained unresponsiveness, or with and without adjunctive therapy. This will be the focus of my talk today. We've already heard about the excitement of Palforzia, the first FDA-approved peanut allergy oral immunotherapy for food allergic patients, so I won't touch on those studies in this talk. The real question is, can the effects of food allergen oral immunotherapy last? So can desensitization last? Desensitization requires the regular ingestion of the culprit food in order to permit its continued safe intake. And if we test how well the food allergen is tolerated in the long-term follow-up periods of daily oral immunotherapy, does the patient maintain the same level of desensitization? If we test for withdrawal to the food allergen after a period of desensitization, sustained unresponsiveness testing, how long does sustained unresponsiveness last? Our colleagues have already studied this in egg and peanut, and this can range between 28% to 55% successful sustained unresponsiveness, and this depends on many factors. The dose of the maintenance dose, how high did they go? How long were they on a maintenance period or interval? And what was the interval of withdrawal testing that was studied? We also looked at sustained outcomes following peanut oral immunotherapy in our POISE study, which I'll tell you a little bit about. This was a phase 2 randomized controlled trial over 3 years looking at 120 subjects. These patients were randomized at the start into one of 3 arms. 60 patients received peanut oral immunotherapy and then discontinued oral immunotherapy, continued with placebo oral immunotherapy in the peanut 0 arm. 35 patients underwent peanut oral immunotherapy and then decreased their dose to 300 milligrams a day for maintenance testing, and this was the peanut 300 arm, and then 25 subjects received placebo. There was only a 13% dropout rate over the 3 years of the study, and the remainder of participants who completed the study were highly motivated and compliant. This is a schematic showing the design of the study, and patients were randomized into one of the 3 arms at the start of the study and then underwent buildup and desensitization to 4 grams of peanut or placebo over the course of the first year of the study, and then maintained 4 grams of peanut or placebo daily over the second year of the study, and then decreased their dose to 300 milligrams or 0 over the third year of the study. In that third year, participants underwent double-blind placebo-controlled food challenges every 3 months to 4 grams of peanut to understand sustained outcomes of desensitization. Our primary endpoint was looking at week 117 food challenges and outcomes. Here I'm showing you the peanut 0 arm in gold, the peanut 300 in blue, and placebo in gray. And looking at the week 104 challenges, which is desensitization, we see that 85% in the peanut 0, 83% in the peanut 300 arm were able to tolerate 4 grams of peanut at the food challenge compared to 4% of the placebo. And then at week 117, we see that 35% in the peanut 0 arm achieved sustained unresponsiveness compared to 4% in the placebo arm. Interestingly, only 54% of those in the peanut 300 were able to successfully pass a 4-gram food challenge to peanut following a decrease of dosing for 4 grams to 300 milligrams daily for 3 months. In this slide, we're looking at the repeat food challenges in that third year every 3 months. Again, we're looking at peanut 0 in gold, peanut 300 in blue, and placebo in gray. And what's interesting to note is that success decreases over the 1-year follow-up in both peanut 0 and peanut 300 arms. So by the time we get to the end of year 3 testing at week 156, we see that only 13% of those in the peanut 0 and 37% of those in the peanut 300 arms are able to pass a 4-gram food challenge to peanut. Even smaller amounts, looking at the 1900 milligram cumulative tolerated dose and the 900 milligram cumulative tolerated dose over the course of the year. We looked to see if there were biomarkers that could predict the outcomes and safety in this study in the blood and in the tissues. Looking at peanut-specific IgEs and IgEs to components ARA-H1, ARA-H2, ARA-H3, and then peanut-specific IgE to total IgE ratio, we saw that OIT success at week 117 was associated with lower values in both the peanut 0 and the peanut 300 arm. We also looked at basal activation tests, and we saw over time that success was associated with lower basal activation in the peanut 0 and peanut 300 arm at week 117. Interestingly, this did not correlate with IgE values. If we classify basal activation tests as high, intermediate, or low responders to peanut stimulation at baseline, when we look at these repeat food challenges over the course of the 3 years, those patients who had a low basal activation responder status were able to tolerate higher cumulative tolerated doses at each of the challenges, and that we see that these individuals who had low basal activation responder status were the ones who were able to be successful and still be in the study at the end of the year 3. So basal activation tests, I think, show promise as a biomarker for predicting disease outcomes and also safety. Safety is paramount and should be part of any study testing for a cure. With food avoidance, allergic reactions related to accidental ingestions of peanut occur at a rate of 12%. With the Palisade study, we saw that 14% of adverse events related to oral immunotherapy were treated with epinephrine. In our POISE study, we saw similar rates in the first year at 19%. But importantly, with continued peanut oral immunotherapy, this decreased over time to 13% and then 0 in year 3. Allergic reactions related to accidental ingestions decreased over time in the peanut oral immunotherapy arm, with 9% in the first year to 2 to 3% in the second and third years of peanut oral immunotherapy. Also of concern when we're thinking about safety for long-term oral immunotherapy dosing is the occurrence of eosinophilic esophagitis. We did have one case of EOE, which resolved following discontinuation of oral immunotherapy. We really were interested in understanding eosinophilic inflammation, and we're fortunate to be able to follow 20 peanut allergic adults in a subset of the POISE study who underwent EGDs with biopsies of the esophagus, stomach, and duodenum at baseline, and then at the first and second year of the study to really further understand eosinophilic inflammation. We were surprised to see that eosinophils are present in asymptomatic food allergic patients at baseline who are avoiding their culprit foods. And here we saw 14% of individuals had eosinophils greater than 15 EOs per high-powered field in the esophagus, which is the diagnostic cutoff criteria for EOE, though they were asymptomatic. Again, we also saw 24% and 29% of eosinophilic inflammation in the stomach and duodenum in those food allergic patients who were avoiding the food. During oral immunotherapy, we were able to assess peak eosinophilic counts in the esophagus. And what we saw is that there was a rise in peak eosinophil counts in the esophagus in those patients who received peanut oral immunotherapy, not in those who were undergoing placebo oral immunotherapy, and that with continued treatment with peanut oral immunotherapy, eosinophilic inflammation decreased at year 2. And these patients were, again, asymptomatic, so this rise in peak eosinophil counts did not correlate with symptoms. This is the first type of pilot study to really look at this, but highlights that risk that eosinophilic inflammation can occur with peanut oral immunotherapy, but it's a complicated picture that is not necessarily tied to symptoms to make a diagnosis of EOE and really warrants further investigation. So to summarize this first part, oral immunotherapy concerns. Desensitization is highly successful. There are some limitations in that it is a slow process. There's potential AEs throughout treatment, which is highest during the initial buildup period. Concern for eosinophilic esophagitis, though we do see eosinophilic inflammation that is not EOE can occur and resolve with continued therapy with peanut oral immunotherapy. There are few patients that are successful in achieving long-standing sustained unresponsiveness, and perhaps there are biomarkers at baseline that may be able to predict who these individuals may be. Optimal dosing protocol is really unknown for long-term dosing to treat single or multiple food allergies, and really how do we address patients with multiple food allergies? This is a study where we looked at over 1,200 food challenges conducted at our center. 70% of patients have allergies to more than one food. And looking at peanut specifically, we see the co-occurrence of peanut allergy with tree nuts, which is not surprising, and egg and milk. And really this highlights the need for a strategy for multi-food allergic individuals. The next generation of treatment strategies for single or multiple food allergic individuals will include protocols with the use of biologics. This is a very busy slide, but really I just want to highlight that there are many promising biologics under investigation targeting different pathways, anti-IgE pathways, anti-allergic cytokine pathways like IL-4, IL-13, anti-alarmin pathways like TSLP, and IL-33. And my next few slides will talk about some of these studies that we've conducted with these biologics. We published our MTAC study, which was a phase 2 multi-center study combining multi-food oral immunotherapy with omalizumab at 6 other sites in Stanford. 70 patients were enrolled and 60 patients were randomized. Everyone received Xolair for 2 months and multi-allergen oral immunotherapy up to 2 grams for 2 to 5 foods for 30 weeks. After 30 weeks, patients were randomized to one of 3 arms to continue a maintenance dose of 1 to 2 grams of each food allergen, or a reduced maintenance dose of 300 milligrams per food, or placebo to test for sustained unresponsiveness. They continued this treatment for 6 weeks and then underwent food challenges at week 36 to assess sustained outcomes. What I want to highlight is these red bars are those patients who continued on 1 to 2 grams of dosing or 300 milligrams of dosing per food. And the gray bar are those individuals who were tested for sustained unresponsiveness. And these are the food challenge outcomes at week 36. And what's exciting is that 55% of those who were tested for sustained unresponsiveness were successful at passing a 2-gram food challenge for 2 or more of their foods, compared to 85% of those individuals who maintained a daily dose of food allergen. 50% of those individuals who received placebo and underwent sustained unresponsiveness testing passed food challenge to 2 grams for 3 or more foods, and 45% passed a 4-gram food challenge for 2 or more foods. This was a pilot study looking at combination approaches for sustained unresponsiveness, which showed some exciting results. So from our learnings from our MTAC study and our MAPX study at Stanford, it really helped us understand combination approaches with multi-food allergen oral immunotherapy and omalizumab, and was the basis of our COFAR application in 2016. And now the Outmatch study is now a phase 3 study through COFAR at 10 sites across the country, enrolling 225 participants. Stage 1 of the study will look at omalizumab versus placebo and looking at changing the threshold sensitivity across multiple food allergens. Stage 2 will look at omalizumab facilitated multi-allergen oral immunotherapy versus long-term omalizumab dosing to assess threshold sensitivity changes. And then stage 3 is looking at dietary food introduction following those approaches. We're very excited that this study is already underway. Next, I'll talk to you about anti-IL-33. So interleukin-33 is a pro-inflammatory alarmin mediating atopic and allergic diseases. AnaptysBio is one company, and other companies have anti-IL-33 drugs that are currently under investigation in allergic diseases. We conducted a phase 2 randomized control study at Stanford and Seattle looking at 20 peanut allergic adults who received one infusion of anti-IL-33 or placebo and then underwent food challenges, double-blind placebo-controlled food challenges at day 15 and day 45 to assess change in threshold sensitivity. What I'm showing you here is in panel A, 73% of those who received anti-IL-33 were able to tolerate 275 milligrams of peanut, and 47% were able to tolerate 375 milligrams at day 15 compared to 0 in placebo. And at day 45, we had continued sustained response following the first and only injection at day 0, with 57% of those who received anti-IL-33 tolerating 275 milligrams cumulative of peanut and 29% tolerating 375 milligrams cumulatively. This was very exciting because it did not involve oral immunotherapy. It was just a single infusion of anti-IL-33. The next slide, we see significant antigen specific, so peanut specific, and antigen non-specific responses at day 15. When we look at panel A, this is looking at peanut skin prick test, which is significantly reduced in those who received anti-IL-33. Panel B shows a reduced histamine response. Panel C shows reduced peanut-specific IgE. And panel D shows reduced total IgE, significantly different in those who received anti-IL-33 compared to placebo. Again, this is exciting to us because we think that this is not specific for peanut alone, and larger studies using this drug are currently being planned. Next, I want to talk a little bit about the promise and excitement with Depilumab, which is an antibody targeting the IL-4 receptor alpha that inhibits IL-4 and IL-13 signaling. There are a number of food allergy studies involving Depilumab currently underway. There is a monotherapy study in peanut allergic individuals. There's Depilumab in conjunction with peanut oral immunotherapy, a Stanford study with Mayo looking at Depilumab with milk oral immunotherapy, and a Stanford study looking at a combination of omalizumab and Depilumab with the NIH. So to conclude, oral immunotherapy has been shown to be efficacious and is a great approach as a first approach. The durability of response requires regular therapy to maintain desensitization for most people, and the optimal maintenance dose and frequency is still under investigation. Biomarkers from the blood may help identify a successful phenotype for long-term maintenance of desensitization. Oral immunotherapy with adjuvant biologics can improve the safety and the speed of single or multi-allergen oral immunotherapy. And we think that the improved efficacy is driven by the ability to tolerate higher doses at earlier time points while reducing side effects to improve long-term compliance. Other biologics with broader mechanism of action show promise to make an impact in food allergy. While there's a lot of excitement for the investigators in the field, our patients are also excited about new therapies to improve their quality of life. And this is a forest plot of a meta-analysis of studies looking at quality of life across studies of oral immunotherapy, showing an overall effect is favorable for quality of life following oral immunotherapy. I'll conclude my talk. Many thanks to FAIR for inviting me to speak, our patients, our families, and our collaborators. Thank you so much for your attention.